disproportionate fat, often in women. The tissue is often painful, and left untreated can significantly impact mobility and quality of life. Lipedema fat is relatively resistant to diet, exercise, and even bariatric surgery. Untreated, lipedema can lead to accelerated osteoarthritis of the joints, progress to secondary lymphedema, and other complications, which can lead to complete disability. So lipedema reduction surgery versus liposuction. So liposuction, as we know, is a cosmetic surgery focused on optimal fat removal for the maximal aesthetic result. Lipedema reduction surgery is focused on pain relief and functional improvement through the maximal removal of all the contents of the hypodermis. So fibrous tissue, extracellular glycosaminoglycans are also important to remove. To adequately debulk, lipedema reduction surgery uses small blunt cannulas, and we remove much larger volumes. And these are generally, of course, the lipedema occurs at all BMIs, and even in very low BMIs, but the average BMI is around 42, and so in these larger ladies, it makes a longer procedure. My average total procedure time is about 4 hours. Lipedema patients also have impaired lymphatic function, so extra care is taken not to damage the lymphatic collectors, and lymphatic injury has been reported in lipedema patients from suction lipectomy. So this is fairly typical lipedema patient she had stage 3 lipedema. She's 46 years old and BMI of 34, which is a little under average, and we removed 1,900 or about 2,000 of fat, and so our total aspirate would probably add a liter into that. And the Renuvion settings were 80%, 2.5 liters, and 6 passes. And those were just retrograde passes. But this is similar, just another view of a different patient. She was stage 2, and at 38 years old, we removed about 3,700 fat and 47 total, and Renuvion settings were similar, 80%, 2 liters, and 6 passes. So we do this on, again, this is a more typical BMI, and again, inner anterior. So she is stage 2, and her BMI is 42, and so we removed about almost just under 7 liters of total aspirate, and the Renuvion settings were 80%, 2.5 liters, and 6 passes, and it really improved her mobility. More before and after of the inner and anterior thighs. This was a smaller lady. She had, almost I would say, kind of a pretty good cosmetic result. But again, the goal is what she did have significant improvement in her pain, and so that's a win-win, which is nice. And here we did lower the power and the flow rate a little bit. And then here's on the arms, and again, this is lipedema, as you know or hope, does affect the arms as well. And this lady, we removed 3,800 of fat, and the Renuvion settings were 80%, 2.5 liters, and 6 passes. And again, she got a very good cosmetic result. She was thrilled, but also her arms were less heavy, less tender, didn't bruise. Even so, when we remove this lipedema, it's not just that they are getting. She happened to get a very good cosmetic result, but even the vasculature in this area, which is prone to bruising and stuff, even that improves. Post-op protocol. So everybody gets in medical grade compression, minimum 20 to 30 at the ankle on up, and 18 to 12, 12 to 18 in the arms. And we really stress medical grade compression for about 2 months post-operatively. We encourage but don't require MLD for two to three times a week for 2 to 4 weeks, and sometimes as an alternate, we use intermittent compression pumps, and then follow them up at 6 to 8 weeks, and we follow their edema, we follow their extracellular water by bioimpedance. We assess their mobility, gait, range of motion, and so these ladies not only are getting improvements in their gait, but they're also we can objectively show that their range of motion in their knees, etc., is improving. So they are getting objectively measured functional improvements. We do crosshatch and overlap. Here are some frequently asked questions. Can Renuvion be used in lipedema? Yes, but there's more skin laxity in lipedema. Lipedema, there's a relationship, so you have to use it more judiciously. Some of them are going to, after this large volume is reduced, they're going to need a thigh lift or an arm lift, but many do not. So there's a relationship with Ehlers-Danlos hypermobility in lipedema. About 60% of lipedema patients do have this hypermobile joints and skin, and so that is part of the reason there's that they're more likely to need tightening procedures or more likely to need Renuvion. So is there a greater risk for liposuction causing lymphatic injury? So before previously there were no PubMed index reports. I've actually in the process of publishing a series of cases of lymphatic injury in lipedema patients from a suction lipectomy. And the exact incidence isn't known. It's very hard. This is to my colleagues here. We don't follow these people long term, and we should be better at following these patients and reporting intermediate and long-term complications. Because as you know, lymphatic. So just like with when you get breast cancer removal, the lymphatic injury, the lymphatic complications really don't present themselves for 6 months to a year post-op. These people, so you really have to follow that out to really know whether that's occurring. And so if you don't know, then you can't really. If you don't look, you don't find it, and if you don't find it, you don't know. So does Renuvion affect pain recovery? It seems to be a little more tender immediately after surgery. And then are there any other effects of Renuvion on lipedema? And we don't know, but we're going to study that. So we're looking at the impact of lipedema reduction surgery with and without Renuvion on pain, lymphatic function, gait, mobility, quality of life, and inflammatory markers, as well as tissue laxity. So I'm really excited that we're going to study this and really help us better understand the disease and Renuvion. In general, we've noticed the recovery after Renuvion is a little more painful, and there's a little more swelling. Now, you have to say in lipedema patients, there's generally more swelling postoperatively. And so there's increase. So there are a greater risk of complications with the diagnosis of lipedema, both in terms of secondary lymphedema, and there's been and reports of fat embolism. So,
what is your feeling about using lipedema fat for fat grafting?
That's a great question, because there's several studies showing that in fact, there's a great study by Ishak showing that the stem cells in the lipedema fat are more robust and are going to survive better. In fact, and it's very so. In that case, I mean, it's the ideal fat for fat transfer. On the other hand, we don't know whether, we don't know what causes lipedema, right? So it's possible that transferring that fat could cause lipedema, and the truth is we just don't know. But we're really, I mean, it's a real exciting time in the lipedema world, because we really are getting closer to knowing it. So I have on a few select patients, I have transferred that and I've told them that it's possible, but we don't know.
It's interesting. I have a patient currently I'm doing breast reconstruction on, and I'm using serial fat grafting, and she has a diagnosis of lipedema. I've done one session so far. She seems to be doing fine. So it's just one of those things that makes you a little anxious if you don't know. I do have another question too about resection of silicone and other products from the gluteal area. What happens when you have a patient where essentially the majority of the buttock skin is affected?
When the majority of the buttock skin, it will depend on the affection. If it's just a change of color, or if it's a change, it has ulcer, or it doesn't have ulcer.
So I can tell you the majority of the patients I see, and I see a few of these in Beverly Hills area, when it gets bad enough, their skin is very thin and purple, and it's got that strange texture to it.
Yeah, and I know what you're feeling.
And it can be a very large area, and it's so large that I don't know if you can resect the whole thing and close it.
I have a patient from Beverly Hills in California too. As a matter of fact, 40% of my patients come from outside of Mexico. Yes, I understand now the question. When you have all that skin damage that is very thin, you need to resect as much as possible, because the problem is that the polymer has gone too close to the skin. So it's obliterating all the vessels and all the structure there. So in order to do that, before I will leave a flap of at least 2.5 centimeters. Okay, you cannot take everything out. Now with the Renuvion handpiece, I will leave a flap of 1.5 centimeters, 1 centimeter, 0.5. Okay, I can get closer to the skin, but that's the closest that I can get. And what I do is I resect, I do a full putocectomy. Those patients, I'm sure they will have the muscle also involved, so I will take a strip of 1 centimeter of muscle, and it's very easy with the precise open handpiece. And from that, I would go up, take, as I told you, as close as 1.5 centimeter, pull everything up, and resect as much as the skin that is damaged, and the rest we're going to have to leave it. Yeah. So after that, I will send them to hyperbaric chamber, 10 sessions. Sometimes they will have 2 sessions one day. If it's too heavy the problem, they need to have at least 2 ATM, 2 atmospheres, or 2.5 ideally. No, I don't leave compression garment on those kind of patients at the beginning.
Yeah, I've done a few of them. They're very frustrating because there's always some up in the dermis, you can't get it out, and sometimes it's very, very deep in the muscle, and you can't get that out.
Yeah, but if you take as much as you can, the prognosis for those patients are much better than living there before they start migrating to other parts.
Interesting, thank you.
Have you ever had to do a tissue expander or a flap or a free flap? Because then you get into a world of trouble.
I don't do microsurgery, so when I have that kind of problems, I would send it to Dr. Santa Maria, which is a very good plastic surgeon in Mexico. But I have done a couple of expander in the lumbar area when they don't have, when the tissue was taken out in order to reconstruct it, yes.
And that just shows you how incredibly serious this problem is, that you can go all the way to not being able to close them with a buttock lift, and tissue expanders, multi-stage, free flaps, tensor fasciolated flaps, all kinds of different things that are just lots of trouble.
And the problem is that these are people that are being scammed by criminals. I mean,
Right.
those guys are criminals.
Kitchen floor, hotel.
Yeah. Right. And if we don't deal with them on an early stages, this is worse than a cancer. It will die, and people are dying from it. And it affects the whole family. The whole family is taken.
Right. Sorry, I thought of one more question. What vessels are you basing your flap on, the lumbar area? Turn it down.
On the lumbar flaps,
Yeah.
on the lumbar, the same, you will do the same as a lumbar flap. The thing is, you're gonna do, what I do is I widen the base at least 10 centimeters. Then you have like an axial and a random flap, and you can go as far as 21 to 25 centimeters long, and then you can raise it and pull it back.
You find you can get enough mobilization, even some of those patients who are relatively young and they don't have that much tissue? Because with the,
I didn't hear you.
you can get enough mobilization with younger patients where the tissues are still pretty firm.
Of course.
Yeah, because I know with the weight loss patients, those tissues are very loose, so you can move them around. But okay.
That you can do with young patients without any problems, or you can mobilize like a Pascal flap for post-bariatric, or an Osan saucer flap that you deepithelialize and you turn it.
Yeah.
We have a lot of options in their area.
Thank you.
So, do you have a question? Please go ahead.
I want to thank both of you. Your talks were really excellent, and I want to encourage you to write this up in the medical literature. This is stuff we need. The one question that I've got for you is, are you seeing insurance coverage for these?
Which one of those?
Both of you.
Both. This is in my case, they are not insured covered.
So the honest answer is that we were getting actually better. So the insurance companies were not covering it at all. They lost a few lawsuits. We were getting, there was a brief window when they were covering it well, and now they are covering it very, very poorly. And it's really unfortunate because it's a terrible problem. I mean, I'm here to tell you something that you already know. Our medical system and insurance system is broken and doesn't work for the people that need it. But that's so there's a little insurance coverage. It's very poor. I mean, they will, for example, right now, I've been paid as little as $180 for a 4-hour surgery. That from the insurer. That's ridiculous.
I saw a graph recently that showed number of healthcare providers like this, and the number of healthcare administrators was going like this, and the entire system is being consumed by regulatory issues, among other things. Did you have another question?
No.
Okay. So most of your patients, you said, had high BMIs of 40 or 42.
The average BMI was about 42 that were diagnosed. I do not do because if they are BMI over 50, I will recommend usually having bariatric surgery.
Mm-hmm.
You know, I'm like 52 maybe because you get some increase in BMI just from the lipedema disease, and so you have to be. The better thing is actually a waist to hip ratio of less than less than 1. But yeah, is that where you're going? Am I answering your question?
Yeah, well, I'm just thinking about patients that have a regional genetic response to hormones and calories. Like I have a regional genetic response to testosterone in my system. And if you look at this fat here, it's metabolically inactive. So I was just wondering if you could comment on these areas of localized fat. And, are the lymphatics inflammatory? Are they just not well formed? It's not like lymphedema. Just some general comments about the regional. I mean, yeah, because insurance companies going to say, oh, your BMI is 42, just lose weight. And that's just a way to get rid of the problem so they don't have to deal with it, but that's not really the issue. Just comment on some of that.
That's a great question. So we don't know actually. There is in most lipedema, certainly in the more advanced stages, by stage 2, which is just there's impaired lymphatics, and we don't know if that is the trigger and the lymphatics are impaired, because it seems clearly hormones are at play. And is that the thing, or is it a genetic thing in the fat cells themselves? But there's clearly this fat behaves biologically completely differently. I mean, by every stretch, from, if you look at the genes turned on, if you look in lipedema fat versus non-lipedema fat, the genes that are turned on, even the fat in the lipid content of the fat is actually different from non-lipedema fat.
Yeah, there's so many questions like the one that Leaf asked about, what can I use it to graft fat? There's so many metabolic issues that we don't know, and there aren't many internists of us in this group to understand that, or geneticists. You, sir, get to have the last question of the conference.
Okay,
So-
thank you, Dr. Thomas, for your presentation. Actually, I had 2 lipedema cases, and these patients tend to be like very grateful patients with the results. The question I have is, have you any experience with like multiple lipomatosis, like mid-lung disease or stuff like that?
So yeah, yes, I've done this reductions on mad lungs and also Derkums and other rare lipomatoses, and they do well as well. I have to say, so some mad lungs, there's really 2 subsets of mad lungs, and the male mad lungs who are drinkers, they really have to stop drinking. So you're not gonna control their lipomatosis unless they also stop drinking.
Well, so that could mean that there's a blastic component as well as a static component, right? Where goes back to talk about stem cells or fat biology.